Hello, everybody. Welcome back to the Fertility Confidence Podcast. If you follow me over on Instagram, and if you don't, come hang out with me at Fertility Confidence Method. I just got back from my honeymoon, made a little bit of a break there, 10 days, skipped a week of podcasting, missed you guys, missed my clients, missed my kiddos, but it was so good to get away. And I had a lot of time to kind of reflect on how important it is to really acknowledge when you need a break. And I think this is not what this week's episode is about, but I think we could spend hours and hours talking about what does that actually look like in the fertility space. But even outside of that, even outside of like taking a break from TTC, but like what does taking a break look like for you and for your soul? For me, it really is like getting out of my house and not having a lot of responsibilities because I have a lot of responsibilities. I also work from home. So I spend a lot of time in this room in particular. If you're watching over on YouTube, you will see that I actually did some redecorating before we left on our trip. I was talking about this on my stories. When I feel very like stagnant energy, I know that that means it's time for me to, shake things up a little bit. And so I've always been like this, even as a kid, as a teenager. If I couldn't sleep or if I was just like bored, I'd rearrange my bedroom. In our like grown up adult house, there's not really like, though we have lots of space, I can't rearrange my bedroom. I can't rearrange our living room. There's none of that happening. So I do find like at least once a year, I'm changing my office in some way. And that helps. It helps me want to spend more time in here, just like cleans out the bad vibes. I set some new intentions. It's great. But another way to just kind of like step outside of that responsibility piece is for us is to travel. It's a great way. My husband and I to connect outside of being parents. But it's also a great way that we recommend our clients to reconnect with their partners if they're feeling a little disconnected through the fertility journey. So, anyways, I had a great time, bucket list trip. I'm happy to be back, but also like counting down the days till we can get back to Hawaii. It is so gorgeous there. One of our team members, our mindset coach, Haunani, lives in Hawaii. I'm so jealous of her. If you live there, oh my goodness. If you've never been, I highly recommend putting it on your list. It was amazing. The other piece that I just want to like quickly touch on before we hop into today's episode, which is for my endometriosis warriors, it's for my unexplained infertility warriors. I had a study pop up into my inbox before we left that I was like, oh my God, we have to talk about this. So that's what we're covering today. But before we do, a reminder that this week is actually boot camp week. So I'm recording this on October 7th. Today was the first day of boot camp. If you're listening to it this week and you haven't come in and joined us in boot camp yet, I highly, highly, highly encourage it. We are going to cover all of the foundational pieces. We're going to build out the next stage of your fertility care plan together. It's me and you live for 5 days. We're giving away over $4,000 worth of prizes. Come hang out with me in boot camp. You can register still at ttc.kelseyduncan.com/bootcamp. Even though you've missed the first day, maybe you missed the second day, you can come in, catch up, and come and join me for the rest of the week. So if you're not in boot camp, please come and hang out with me in boot camp. The last piece of housekeeping, I'm actually going to grab my water because I was losing my voice in our first boot camp day today, which was annoying. I don't want that to happen here. So I'll grab my water. But the last piece of it, little housekeeping is I just want to say thank you to our wonderful sponsors over at Needed. They're actually giving away a $250 prize pack as one of our grand prizes in boot camp. So taking care of your supplements for a few months, which is so generous of them. But Needed is a wonderful company that has put together some really amazing and research-backed products for you on your TTC journey through pregnancy and beyond. And you can check out more over at thisisneeded.com. Using the code Dr. Kelsey gets you 20% off your first order. And I'll actually pop the link for you to use right in the show notes or in the email. If you are a subscriber, you'll get that sent right to your inbox. So thank you, Needed. Okay, let's talk endometriosis. This is a topic of conversation that has been very hot inside Fertility Confidence Method this year in particular. And It's something I think we could spend hours and hours and hours talking about. Today, we're specifically going to cover a study that came into my inbox a couple of weeks ago that was released earlier this month, called The Prevalence of Endometriosis and Unexplained Infertility. And when I found this in my inbox, so every Sunday I get sent all of the new PubMed articles for all things fertility. I have all these keywords set up. And when I saw the title of this, I was like, oh, yes, here we go. Like, this is the type of information that we need to really get testing into the hands of women. So, for those of you who maybe aren't super familiar, if you're not in the endo community, but you're in the fertility community and you're starting to kind of question, like, where do I go from here? What else do I need to look into? Endometriosis is one of those women's health issues that is not well managed in medicine, and it's challenging to diagnose. So the really gold standard, we call it gold standard, the best way to diagnose endometriosis is by doing laparoscopic surgery. And, logically, it makes sense that we aren't just lining up a bunch of women to do exploratory surgery. It's expensive. It's laparoscopic, but it's still invasive. There's a lot that goes into that. Logically, I get it. But in the pocket of the fertility community, we are doing couples a huge disservice by not exploring this as an option earlier on in the diagnostic workup. And that's kind of what this study, when we're talking specifically about unexplained infertility, is really showing us. And then I want to walk you through a newer-ish way that we're seeing diagnosis being made in the fertility space that I do think is really going to open up the door. So endometriosis is something that we know greatly impacts the fertility community. And I think I have a statistic here when we're talking about unexplained infertility specifically. So we know that about 15 to 30% of couples who are dealing with infertility are deemed unexplained. That's one third almost of couples where they're like, you're not getting pregnant. It's been over a year. You're not getting pregnant, and all of your blood work looks good. You'll know if you listen to the podcast over the years that I have a hard time with this unexplained diagnosis for many reasons. I think that it exists, but I also think that we're throwing this term at couples way too early in the diagnostic process, meaning there's a lot of things that actually still aren't being looked at, and we're taking a very surface level look and being like, hormones look fine, it's unexplained, when in reality, there's a laundry list of explanations. And this is actually a new masterclass that I'm working on, specifically is talking about unexplained infertility. But so 15 to 30% of couples are getting this diagnosis. Whether that number is accurate, I'm not sure. I've even had some couples where they're like, oh yeah, my thyroid's off, but they told me it's unexplained. That's not unexplained. Your thyroid is giving us an explanation. But anyways, I digress. So this first study looked at couples with unexplained infertility and what are the chances that they have endometriosis. So they took, I don't know how many women actually, and I'm not going to waste your time while I scroll through this, how large the study was, but their parameters basically were they hadn't gotten pregnant in a year or more, they had normal ovulatory cycles and a normal semen analysis. So no male factor. What normal ovulatory cycles means in terms of what else have they looked at, I'm not exactly sure, but that was kind of their minimum requirements to be included in the study. And what they found was that 44% of those people who had been told they have unexplained infertility actually had endometriosis. 44%, that's almost half, which is mind-boggling to me. And they weren't looking specifically at women with symptoms. They were just looking at, have you gotten pregnant and have you been deemed unexplained and do you not have male factor, which is insane. 74% of them were deemed to have minimal or mild. So a large portion of those people, which likely tells me that it mostly wasn't symptomatic, which we'll talk about in a second. but mild to moderate. Now, that doesn't mean it's not going to be impactful. They then found 20% of women had tubal issues, and then 16% of women had adhesions. So these numbers aren't as large as like endo was found, but we're now seeing that there could potentially be other issues, not just that the endo is there. They also found, which I thought was interesting, that there was a higher rate of pelvic abnormalities in women who had done fertility treatment prior compared to those who hadn't. So 75% of the women that they found had endo had done fertility treatment, whereas 53% hadn't. Is the treatment making it worse? Potentially, unsure. Or were they just already exploring those options because they were struggling and it was the endo that was the cause? The really like bare bones of this study is saying that almost half of the women in this group who were told that they have unexplained actually had very explainable fertility issues, but no one was friggin' looking for them. And that's the part that boils my blood. And it's so funny. We talk about this in Fertility Confidence Method all the time, but things come in clumps. So whether it's because one or two people bring it up and then all these other people come out of the woodwork going, I have a question about that. I have a question about that. Or whether the universe is like, here, Kelsey, you need to learn everything you need to learn about this. Here's like 25 clients that all have the same problem. This has been the year of endometriosis, and not just endometriosis as a whole, but a lot of our clients who we're finding actually have silent endometriosis, meaning they aren't exhibiting the typical pain symptoms that we would expect with endo. And yet when we're pushing and pushing and pushing for diagnosis because nothing else has worked, it's actually coming back positive. And that's always a really scary thought. So I want to acknowledge that, especially if you're early on in your journey. I hate talking about silent endo. I really do, because I honestly find that it's triggering, right? If you're sitting there going, oh God, my blood work looks good, but I'm not getting pregnant. Now we're snowballing into, do I have this? Do I have that? And the reality is that you might. Unfortunately, 25% of women with endometriosis are asymptomatic. 1/4 of women with endo don't have symptoms. And this is something that we really need to start taking into consideration when we're just throwing out an unexplained diagnosis, especially after medicated cycles haven't been successful. The unfortunate part of all of this is I'm often not seeing this diagnosis without symptoms, even with symptoms, sadly, which boils my blood even more, being taken into account and until there's been failed IVF. And I'm hoping with more research, we're actually going to start to see a change in that. We're going to start to see more push towards looking at this as a possible diagnostic option earlier. Similar with microbiome stuff. We know from other studies that like 50 to 75% of women in those pockets with unexplained infertility had uterine microbiome issues, and treating it drastically increased pregnancy rates. Like, we cannot ignore these things if you've been told it's unexplained. So let's talk a little bit about how we actually test. So I already mentioned the gold standard of care is laparoscopic surgery. And sure, we're not like lining every single person up who's not getting pregnant for exploratory surgery. I get that logically. But the practitioner in me that wants root cause answers hates that for you. Honestly, I think we should just be able to investigate. And so over the last year, I've done a lot of digging in terms of like, well, how else could we maybe advocate for treatment and testing? And a few things come up in the research. One is a blood marker called CA125. There is some data. I don't have the stats right in front of me. I think it's like 75% specific to endo. So it's not a perfect marker, but it is something that, if elevated, may be related to endometriosis. If it's negative, it doesn't necessarily mean that endo's not there. That's what I mean by it's not a perfect system. The other thing to remember with CA125 is that it's also a marker of ovarian cancer. So if it is high, we always want to do due diligence and just give those ovaries a quick check, make sure there's nothing else going on, do a CBC, and just obviously be careful. That is one way over the last, I would say 5 years, that was being talked about in the literature of how could we maybe get a diagnosis without surgery. And it was probably one of our more better options. The two things that I'm now seeing a little bit more frequently over this last year in the fertility community, one is MRI. It's still not as good as laparoscopic surgery, but it's significantly better than ultrasound. There is diagnostic ultrasound. I'm not really seeing that in the literature. I'm also not really seeing that like up and coming in clinics. I'm in Canada, and I know here in Canada, there's 2 practitioners, 2 endo specialists that are using diagnostic ultrasound in their clinic. And it's like a 3-year wait list to get in with either of them. One's in Ontario and one's in BC. And it's just not seemingly to be kind of snowballing into more options or being commonly used. That doesn't mean that it's not probably something maybe happening more in the US. I'm not sure. However, it's a very specific ultrasound. It's not just like your basic run-of-the-mill ultrasound. The tech needs to be properly trained in terms of knowing what to look for and where to look for it, because it's not just like a typical look-see in the uterus. There's like hidden areas, right? So we cannot diagnose it through ultrasound, standard ultrasound, but MRI is an option. Again, we're not really lining women up for MRIs, but it is something to perhaps push for that might be more readily accepted, available to you beyond surgery. It's something, again, a trend I'm starting to see just this year in 2024, that more clinics are like, okay, you're worried about this, fine, let's do an MRI and see. So I think we'll see more MRI. But the second thing that we're seeing more of is actually a uterine biopsy. So I wanted to go through this other study that, what is it called? It's called, Can We Accurately Diagnose Endometriosis Without a Diagnostic Laparoscopy? So this paper in particular, it's from 2022. I think we'll see more of this, is actually coming out of looking at a biopsy of the uterine lining for a specific, what do we call it? Like genetic chromosome thing. That's not what it's actually called. That's a terrible way to describe it, but it's called BCL6, proto-oncogene chromosome 3, and it stimulates inflammatory cytokines. So when people are doing, you might have heard of the Receptiva testing, and this is typically where they're actually screening for this specific BCL6 protein. So they're taking a little sample of your uterus, of the lining, and they're looking like for inflammation, basically. And when this marker, this inflammatory marker, is high in the uterine tissue, it's very greatly scored towards possible endometriosis. So this is what we're seeing being used more. I don't actually, you know what? It's so funny. I didn't see a lot of Receptiva. I don't particularly think the research lends to the idea of progesterone receptivity improving implantation rates with FET, which is typically what we were pushing Receptiva for. But having this specific marker checked for, especially if you have unexplained or if you've had repeated implantation failure or repeated miscarriage, I think is so, so crucial. Because when we see high levels of BCL6, we're also seeing high levels of other inflammatory cytokines, specifically IL-6, which we know if we dig into that research, the immuno implications and how that impacts the uterine environment and microenvironment is so important. And so they're seeing higher levels of inflammatory cytokines when BCL6 is present. And why we care about this from a fertility perspective is actually for 2 reasons. So one is that the BCL6 actually binds and inactivates the regulators of the progesterone pathway. So for all of you women who are like, I feel like my progesterone is low, but my blood levels are good, are we potentially not actually using our progesterone appropriately? Maybe. And this is one of those things that over the years has always kind of eluded us and me specifically of like, okay, we know there's progesterone receptors. We know that they can be impacted, but like, there's no way to check for that. And this is now one of those ways, again, it's not uber specific to like, absolutely, this is happening if you have this, but potentially it is. So now potentially leading to what we would call progesterone resistance, meaning you do make good progesterone, but are you actually using it appropriately? Perhaps not. That's then maybe leading to implantation failure or recurrent miscarriage, which is really, really important things to know. So we have this potential implantation receptivity impact with the elevated inflammatory cytokines, and we also potentially have significant progesterone resistance and progesterone implications when we're talking about this specific BCL6, but also how endometriosis itself can impact fertility. And I think a lot of times when we hear endo, we think, okay, if I have endo, then that's likely just impacting implantation in terms of physical aspects of lesions, but there's so much more to it than that. We talked about this on my stories yesterday, actually. There's so much more to it than that in terms of the actual inflammatory and immunological environment that is created when endometriosis is present. So this biopsy is like our next best option, honestly, in terms of advocating for diagnosis that sure, you're going in, you're taking a biopsy. It's definitely not going to be pain-free. It's going to be one of those like little pinch, pressure coming and then be done with it. So I don't want anyone to think it's, easy peasy lemon squeezy, but it's quick. It's easy, and honestly, it's accessible, and it's significantly more accessible than laparoscopic surgery at this time. And what we're seeing in this paper specifically is that it's actually probably a really, really good option. So what they found, so how they score the BCL6 is they use something called an H score. So anything over 1.4. So if you have BCL6 over this 1.4 level, it's associated with poor IVF outcomes and recurrent miscarriage. So, and then the endometriosis piece. And what they're actually looked at here is that when the underlying causes of the inflammation that's present because of the endometriosis, when that is actually being treated, which what I chatted about on Sunday was looking at aspirin in fertility and endometriosis usage. But when they found that the inflammation was treated, the live birth rate went from 7.4% in controls to 50 to 76%. Like, what a jump. And then what they found was that 94% of patients that tested positive for BCL6 then went into laparoscopic surgery and had endometriosis. 94%. Good enough for me. Like, that is a really, really high success rate in terms of this marker being positive. Another study, this one was done, I'm not sure, actually a couple of years ago, but they took women going through IVF. They found the BCL6 overexpression. So BCL6 was high. They did the laparoscopic surgery. They took out the endometriosis, and they had 75% had confirmed diagnosis with laparoscopic surgery. So of everyone that had overexpression, 75% had confirmed diagnosis. And then 21% actually also had what they called ovarian endometriotic implants. So I'm assuming they were talking about endometriomas. I would have to open this up. So they actually wouldn't have even needed to go in and do laparoscopic surgery. They would have seen that on ultrasound. The cool thing here is that post-op, they followed for 6 months. So they did the lap, they removed the endometriosis, they followed these women for 6 months, and there's a clinical pregnancy rate of 90%. 90%. Like, I'm not going to spend time talking about like surgery versus no surgery, what's best. I think there's still a lot of conflicting information out there, and working with an endo specialist is incredibly important. But even in this small study, they found the BCL6 overexpression was fairly confirmatory. They also found that after removal through laparoscopic surgery, they had a 90% clinical pregnancy rate. Did they continue following to see live birth rate? No. obviously when we're looking at fertility research, we want to see live birth rate, but this is the best we got right now. So we'll take it. That is huge. And so I wanted to do this today because we actually talked about this in office hours this morning. We talked about it in office hours before I left for my trip, of women who were in this phase of their fertility journey of unexplained. We've tried everything. IVF hasn't been working. Before we do anything else, like, this is the number one question I get. Dr. Kelsey, what else can I do? What else can we look at? What else can we try? And this is always, always, always something, regardless if you have symptoms or not, that I think it's just worth ruling out. Whether you can do that through surgery, first and foremost, or through doing the BCL6 biopsy, I think this is a really great, less invasive option for us to just get a better understanding, knowing that in this prediction, at least 94% of patients who were positive had confirmed findings. Whether that was mild, moderate, or severe, I'm not sure. But the reality is that with 25% of women being asymptomatic with endometriosis, we cannot ignore this, even if you don't have pain. But we also know from older research that if you have pain with your period and you are unable to get pregnant, it's like a 75% chance that you have endo. These are not small numbers. 50 to 80% of couples with unexplained infertility are dealing with endometriosis. We need to be seeing quicker diagnostic workups for our unexplained and our recurrent loss couples, beyond just continuing to try and pay for IVF and hoping something's going to change. We need to see this happen. And this is where, unfortunately, you as the patient need to come in and just really start advocating for yourself. If you're in this bubble of where do I go from here, and you haven't had this investigated, it is worth the cost, and it is worth the advocation for yourself. Because if it comes back negative, okay, cool. We can at least, know it's not an answer, but it is in a way us checking a really big box. So if you are in the unexplained category, I recommend going back and listening to our unexplained episode. If you haven't already, make sure that you subscribe so you don't miss any future episodes. I'm going to pop both the links for these studies in the show notes for you. So if you are a research nerd like myself and you actually want to read through them, there's some really cool links on the PubMed of they always give you other studies that reference this. You can really fall down like a deep rabbit hole when it comes to endometriosis. I hope we see more research in this area. And for those of you who are kind of wondering, where do I go from here? Or have I checked all of my boxes? Hopefully this was helpful for you, and I'll see you guys in the next one.